Michigan, known as the Great Lakes State and the home of the American automobile industry, is where you'll find Arlene Younger. Arlene is in her early 70s, but that doesn't stop her from ballroom dancing, hiking through local nature areas, and enjoying all that life has to offer. What does stop Arlene is a condition she's been dealing with for more than 2 decades: overactive bladder.
Well, that started about 20 years ago. And at that point in my life, when I was starting to have issues and problems, I thought, wait a minute, this just isn't supposed to be. It really crept on up pretty fast. I was waking up a lot at night. However, very quickly, I began to have to wear light protection. I found that the urgency was coming on very rapidly.
Arlene is not alone. There are millions of men and women in the United States affected by overactive bladder.
There are 33.3 million adults in the United States that suffer from overactive bladder. And unfortunately, only about half of those present for treatment. And 66% of those patients, the reason why they seek treatment is because now they're incontinent of urine.
57-year-old avid golfer Louise Wendell had a disastrous first experience with overactive bladder while in a drugstore.
I was standing in a puddle, and I was extremely embarrassed because my bladder, I just lost control of my bladder. And I gathered up my son and quickly got out of the store as quickly as possible, and was devastated that something like this happened.
So overactive bladder is really the need to go to the bathroom when you don't want to. So it's the urgency frequency, or like you see on television, like the gotta go syndrome.
Frequency is defined in the urologic community by voiding more than 8 times a day. So if you urinate more than 8 times a day, I like to see at least 2 hours between urination to consider that normal. Now, for some people that might not be enough. That's not normal for them. They want to go 3, 4 hours in between. But I strive for 2 hours and tell people they should be happy it's 2 hours and not every half hour, like some of my patients suffer from that much frequency.
For Arlene, the need to go came on suddenly.
Sometimes driving in the garage, put the garage door down, and psychologically it must have been you're safe, and having accidents that over the years began to get very, very severe, full-blown loss of urine.
To better understand overactive bladder, it's important to see how the bladder is supposed to work. It's surprisingly simple. Our bladder is a hollow muscle. Its sole purpose is to store urine and then contract to release urine.
So the way the bladder functions normally is it has lots of receptors in it. In other words, the bladder can sense as it fills. And so as the bladder fills, it sends signals up to the brain. And then everything gets processed in the brain. In a normal function, you can control that, and you decide you're going when is the appropriate time to go to the bathroom, and you could typically hold your bladder until that time is there. And then when it's time to go, it's the same signals from the brain that allows you to relax and urinate normally. Overactive bladder, there's a signal problem. The communication between the bladder and the brain don't work the way they should.
After her accident in the store, Louise immediately went to see her primary care doctor, who referred her to a specialist, who diagnosed her with overactive bladder. For some patients, the signs and symptoms of overactive bladder may be indications that there are other medical conditions. But there was no underlying cause for either Arlene or Louise. In both cases, the condition came on suddenly and progressively became worse to the point that it was interfering with their quality of life.
It controlled my life. It does. As much as you say that you can work through control and find avenues to manage your life. No, it has been a lifestyle.
They're embarrassed. They find all these coping mechanisms. I've got some patients that know where every bathroom is in the entire county, and they can tell you which ones are nice and which ones aren't. So they won't go out unless they know there's going to be a bathroom and that they can get to that bathroom quick enough. They change their life. They change the way that they do things.
When overactive bladder starts interfering with the patient's overall quality of life, seeing a medical professional for proper diagnosis and treatment may help. Sometimes it's the sleep lost due to waking up in the middle of the night that has patients seeing their doctor.
The most common concern of women with overactive bladder seems to be the lack of sleep, because many of them are getting up at night at 4 or 5 or more times at night. And when you don't sleep well, it impacts how you function during the day. Many of these women have children to care for, they have to go to work, they have families and household things to take care of. And when you're tired all the time, it really impacts your quality of life.
Arlene and Louise both were put on prescription medication to control their symptoms, but after a few months, they realized that drugs were not addressing their problems.
75 to 80% of patients who start on medicines for overactive bladder are not on them a year later. And part of it is due to cost, due to side effects, and due to lack of efficacy. So unfortunately, despite millions of patients having overactive bladder, the medicines really help probably a small percentage of them.
To help the rest of the patients, researchers in the 1980s started working on another way to treat overactive bladder called neuromodulation.
The signals have to go from the bladder to the brain and back down to the bladder, and we should be able to control what happens. And those signals get messed up in overactive bladder. The wrong signals are being sent. So it was in the 1980s where neuromodulation was looked at, and the nerves that come off of the area of the tailbone, the sacrum, actually are the main nerves that control the bladder, and it's called your sacral nerves.
These researchers discovered two ways to stimulate these sacral nerves. While the effect is similar, the approach is drastically different. One approach, sacral nerve stimulation, is very direct and uses a small stimulator implanted near your spine.
So it's like a pacemaker for the bladder.
While this bladder pacemaker has been successful in many patients, it does require surgery. And as with any surgical procedure, there are always risks associated with it, including risks of infection and complications of anesthesia. So surgery is definitely not for everyone. The other form of neuromodulation approaches bladder control from the ground up, literally. Researchers discovered you can provide indirect stimulation to the sacral nerves using a small needle inserted near the tibial nerve, which runs from the ankle up the leg to the pelvic area. This approach is known as percutaneous tibial nerve stimulation, or PTNS.
All of our nerves originate in the spinal cord. And then the spinal cord branches off, and then you have nerve fibers that come out of the spinal cord. And the nerves that innervate the bladder primarily are the S1, S2 nerves, so they're the sacral nerves. And as those nerves come out of the spine, they branch, and they branch, and they branch, and they branch, and they extend down. And what happens is that the posterior tibial nerve and the S1, S2 fibers that innervate the bladder all stem from the same level of the spinal cord. And so that's why you can neuromodulate a nerve that is distal or very, very far down and away from the body. And the reason why we pick that nerve is because it's so superficial to the skin.
An office procedure where a nurse or nurse practitioner could perform it. The tibial nerve stimulation is painless to put in. The stimulation, you feel a little pulsating. You might see the toes move a little bit. That's just suggesting that we're stimulating the correct nerve. And again, it doesn't work by stimulating your foot. It works by sending the signal up to the brain.
Patients can speak with their primary care physicians about being referred to a urologist, a urogynecologist, or a gynecologist who can discuss the PTNS procedure. Now the question is, how does PTNS control the problem? Unlike prescription medicines, which have to be taken every day for life, or the implantable stimulator, which stays in the body, this approach has a different process.
With tibial nerve stimulation, a little different is instead of doing it every day, we found that you can do a treatment once a week for 12 weeks. And then what we found is that most patients need about one treatment a month after they get better with the initial 12 treatments to maintain an improvement.
Arlene began receiving her nerve stimulation and has been doing great.
Throughout the day, I was holding urine more. I wasn't changing my protection that often. And I thought, hey, this really is working. And then I kind of slipped backwards a little bit. And finally, around number 10, it was like snap of the fingers. I began to see a huge, huge difference. Sleeping, only getting up once a night, getting more rest, not wearing protection. I haven't worn protection in a month now. And it's a simple treatment. It's like freedom. There's just a sense of freedom and joy.
Louise has completed her treatment and is now managing her overactive bladder. She has reclaimed her life and resumed a level of activity she had only dreamed of.
Going forward is that all I can see is things going up. I mean, it has improved my quality of life, and it has proven that it works. This procedure works.
For more information on overactive bladder, please visit urgentpctherapy.com or the National Association for Continence website at nafc.org.